Production and distribution of City Club forums on IdeaStream are made possible by the generous support of PNC and the Raskin Family Fund, with additional funding from Robert Conrad, Cleveland State University, the Chautauqua Institution, the Cleveland Clinic, and the United Black Fund of Greater Cleveland, Incorporated.
Good afternoon. Welcome to the City Club of Cleveland. I am Dr. Donald Ford. I'm the Chief Medical Officer of Better Health Partnership. I will take one moment off script because I was invited specifically by Dan to say if you'd like a moment of solitude and beauty after the presentation today, you can stop over at the D.K. Ford Library, which was named in honor of my grandfather, David Ford, who was a City Club member from very early on, I think right after the Mayflower, somewhere around there. And he was a passionate believer in free speech and the sharing of ideas. So it's a great honor always to come up here and see that little recognition. But especially today, I am pleased to introduce the forum, a panel conversation focused on the importance of community health planning. Despite being home to some of the most innovative healthcare systems in the world, American citizens' life expectancy is oftentimes determined solely by zip code. Citizens living in poor, primarily minority communities, whether urban or rural, suffer from more complicated health problems, often lack access to effective health care, social support services, and die much earlier than necessary. Community assessments and planning are one component for reducing these disparities and reducing the overall health and improving the overall health and well-being of individuals. Ohio has several initiatives underway. Today, we'll assess how they are faring and how local and state government effectively can collaborate with healthcare systems, nonprofits, and social service agencies to effect lasting change. Our program today is a little different than our standard forum. First, we'll hear a short presentation from Dr. Clint Koenig, Medical Director at Ohio Department of Health. Then Dr. Koenig will moderate a panel with local experts on community health planning. Finally, we'll have our traditional City Club Q&A. So let's begin. As Medical Director of the Ohio Department of Health, Dr. Clint Koenig advises the Director of Health on clinical and medical issues as the agency fulfills its mission to protect and improve the health of all Ohioans. He has experience in the transformation of healthcare delivery in multiple settings, including public health, primary care, multi-specialty clinics, managed care, and care coordination. Dr. Koenig previously served as State Medical Director for the New Hampshire Department of Health and Human Services, where he served as physician liaison and advisor to the Health Commissioner. Dr. Koenig received a bachelor's degrees in biochemistry and in history from Skidmore College in Saratoga Springs, New York, and a medical doctorate degree from Albany Medical College in Albany, New York. He completed his medical internship at Metro Health Medical Center in Cleveland and completed residency training in family and community medicine at the University of Missouri, Columbia, where he also received a master's degree in public health and in journalism. Ladies and gentlemen, members and friends of the City Club of Cleveland, please join me in welcoming Dr. Clint Koenig.
Thank you, everyone. I'm humbled to be here, to be talking in the footsteps of incredible presidents and dignitaries. So just a couple of things to clear out of the way. The first is I'm not running for governor. and the second is I'm no Jack Kennedy. I was asked today to speak about the importance of community health and why it matters more than ever. And I believe we need it more than ever for two reasons. The first is that all health care is regional. And the second is that effective regional planning represents our best hope to improve quality and help bend the cost curves. And I say that because throughout the country, we've realized mixed results for major healthcare redesign models. Patient-centered medical home efficacy is diminished when recognized practices have less access to continuing resources and financial support. As a former PCMH reviewer from NCQA, I saw firsthand how this could be the case. And accountable care organizations may not be delivering savings in sustainable ways. A 2017 study in Health Affairs published this past December found that the savings from the Medicare Shared Savings Program were not as a result from decreased ambulatory sensitive conditions or from high-risk patient care coordination. Initiatives like these represent our best fire line to our cost and care problem in this country. We are all familiar with the issues nationally, and as many as you know, the problem is also in Ohio, where equality and equity in spending place us in the bottom half of all states nationally. The 2017 United Health Fund ranks Ohio's quality 39th of all states. And according to the Health Policy Institute of Ohio, state healthcare spending ranks 31st out of 50 states. And unfortunately, Cuyahoga County fares poorly in key outcomes according to the Robert Wood Johnson Foundation. The Foundation's 2017 health rankings place Cuyahoga specifically at 65th out of Ohio's 88 counties in health outcomes, below both Hamilton, which is in Cincinnati, and Franklin, Columbus. Specifically, the county ranks 76th with the number of children in poverty and 63rd in diabetes monitoring. And yet the region possesses some of the best healthcare delivery systems in the world. The latest U.S. News and World Report ranks Cleveland Clinic as the #2 ranked hospital system in the entire survey. University Hospitals has national recognition in 8 specialties, and Metro, always a soft spot in my heart, is the most community-focused hospital in the country. And the region is fortunate to also have forward-thinking behavioral health systems as well. When I ponder the numbers, I'm struck about an obvious issue. We have great regional health delivery, yet the region lags way behind in quality and in outcomes. We have a disconnect in our health system delivery chain, and that is a problem. These health-centric models cannot alone fulfill the Herculean task of improving population health and care coordination. People are cared for when communities are cared for. Hemoglobin A1Cs do not improve unless adequate food security improves, along with maintenance of stable housing within trauma-free communities. And individuals get cared for when they possess the navigational knowledge within seamless, coordinated service systems. Regional resources exist. In 2016, the Greater Cleveland Food Bank produced more than 50 million meals for the region, as an example. And that works out to about 40 meals for every man, woman, and child in Cuyahoga County alone. Other resources provide literal life-saving ability in the areas of rental assistance, transportation, heating assistance, and others. And given the connection between social determinants and health outcomes, it's little wonder that our region and nation is where we are. If we could all wave our wands and allow these valuable resources to link together and coordinate and join other sectors hoping to solve the same problem, we'd be in a far better place. Public health has a vision, community-based organizations have a vision, and as I've discussed, so does the healthcare community throughout the delivery innovation spectrum. What's needed is a table large enough and broad enough to coordinate the bounties created by all in this region. Communities thrive when communities coordinate, and the solution is community health planning. While I mentioned that a good regional planning model is all local, I'd also like to take a moment to call out the state initiative designed to encourage regional health planning conversation. The state of Ohio has a health roadmap to help move the needle called the State Health Improvement Plan, or SHIP. Key priority areas which Cleveland and Northeast Ohio are hard at work on include infant mortality, behavioral health, and chronic disease mitigation. And what's notable about our state plan is that it provides a platform to allow regions to talk the same language and also to be consistent around reporting to one another around these activities in their regions. One of the key struggles across the region and the state is our infrastructure to coordinate services between health and non-health entities. One solution to this issue is facilitating better regional health planning between hospitals and public health departments. The Ohio Department of Health has been tasked to help ensure that these entities embrace a comprehensive assessment and planning process, bringing all relevant community stakeholders to the discussion. And it's our desire, and the desire of many, to create a regional playbook for each regions within the state to ensure inclusive and coordinated regional planning. We know that discoordination of care is costly. Research published in the 2015 American Journal of Managed Care suggests that highly fragmented care, defined as patients with multiple conditions and multiple provider and community referrals, substantially increases the risk of avoidable hospitalization. It also increases the number of gaps in care. A 2012 seminal paper by Dr. Don Berwick from the Institute for Healthcare Improvement and published in the Journal of the American Medical Association suggested that failures of care coordination resulted between $25 and $45 billion of wasteful spending in a year. Without coordination and without that air traffic control, services collide or offer redundant, duplicative services. One of the key root causes in coordination failure is, no surprise, communication. Ensuring tight communication linkages and pathways between seemingly disparate systems are critical, such that hospitals, behavioral health, community-based organizations, and public health agencies seamlessly coordinate. Interoperability between all these agencies and entities are a challenge. And the good news is that challenge is becoming reduced in some of the new pioneering work through Better Health Partnership and their ability to demonstrate interoperability between medical and community-based activities. Other well-known coordinative barriers include the time and the resources to align. In the health systems, we only have to remember that transitions of care and their subsequent payments have come about only in the past 10 years. And unfortunately, in our current state, transitions of care between community-based organizations and health facilities go unreimbursed. Another coordination failure that I've noticed is the discoordination of case management and case management coordination, and who coordinates the coordinators. In an area that I've worked in, I saw one individual with no less than 4 case managers for health, managed care, behavioral health, and social service needs. And finally, there's the critical element of creating a culture of collaboration, which Northeast Ohio is doing a fabulous job at. Even despite entities with so many overlapping business models. I've heard this model called co-opetition, and it's not just limited to health systems. Community agencies with overlapping service and grant dollar competition need to best define their role in providing linkages to better coordinate services. Much of the structure of regional planning lies in the intersection between traditional health providers, public health, and community health organizations. Each does well in their own domain of service. The key is to enjoining culture, workflow, and communications between these services to allow better information flow and organizational alignment. Despite these challenges, we know that prompt interagency communication improves health outcomes. Recent research in the journal Population Health Management showed that increased referrals to the Supplemental Nutrition Assistance Program, or SNAP, resulted in decreased inpatient hospitalizations, as well as a 23% reduction in nursing home admissions. And we know that spending on the community health side has been shown to improve chronic conditions such as adult obesity, asthma, and type 2 diabetes, among others. Regional health improvement works because of improved and seamless coordination with all community service sectors. When partners from housing, behavioral health, business, public health, and the medical community are at the table and willing, results can happen. It's mindful planning, assessment, coordination, and execution that ensures the needs of the individual and the community are simultaneously cared for. Northeast Ohio has some shining examples of regional health collaboration. One such collaborative we'll be hearing about in a few minutes is the Health Improvement Partnership of Cuyahoga County, or HIPC. Its model of diverse collaboration has garnered statewide notoriety in pioneering approaches to community health partnering and planning. Another is our own Better Health Partnership. Their collaborative improvement model, just published in the Health Affairs, helped improve care and reduce avoidable readmissions by providing endorsed quality measures, public community reporting, and workflow innovation and redesign coaching. Those efforts helped avoid over 5,500 hospitalizations at a cost savings of nearly $40 million. Better Health brings a rich database of clinical outcomes as well related to chronic disease, consisting of over 500,000 adults and children that can and should be leveraged for community and regional health improvement planning. When services coordinate, community good happens. And when community good happens, good policies can be created from the bottom up. So where is our future for regional health planning? Within the medical neighborhood, providers, public health, behavioral health, and community organizations are beginning to adapt new strategies to embrace regional health collaboratives. All in Northeast Ohio, as well as around the state, must be at the table to produce a mutual and comprehensive regional assessment. And as I mentioned earlier, that assessment needs to serve as the playbook for all to follow in the region to minimize unnecessarily overlap in planning and execution. Public health strategists have realized our public health infrastructure needs to better integrate into the medical neighborhood to better serve its community. The Centers for Disease Control and Prevention is creating the new Public Health 3.0 plan to encourage health departments to engage with community stakeholders to form vibrant, structured, cross-sector partnerships with the hope to foster funding, shared services, governance, and collective action improvement. Through the new community planning cycle process for the state, hospitals are now working closer than ever with public health and community through more comprehensive and thoughtful planning on what community needs are out in their respective regions. And hospitals, through greater interactions with public health and community-based, are looking beyond their four walls and embracing populations beyond the typical attributed patient population. Community-based organizations are increasingly building much-needed interdependencies within the medical neighborhood. A few examples include recent recipients of the Ohio Department of Health's new Community Smoking Cessation Initiative, which recognizes multi-agency collaboration as critical to tackle Ohio's persistently high smoking rates. Another exciting initiative involves a new grant awarded to the United Way of Greater Cleveland to promote accountable health communities. We'll learn more about this shortly with our panel. These emerging interdependencies are critical for success in the region. Building a common foundation helps ensure common expectations around execution, particularly around reducing health disparities, promoting health equity, especially in the areas of greatest need. The future in regional planning lies not only in successful results, but in sustainability. Interagency coordination, like transitions of care, must be sustainable. Fortunately, these coordination models are becoming sustainable amongst the payment systems both statewide and nationwide. Medical-based care coordination, as many of you know, are taking place locally, and these include the CPC Plus, or Comprehensive Primary Care Plus program through Medicare, as promoting care coordination through payment of medically based care management for Medicare beneficiaries. Ohio CPC is following suit in providing care coordination for Medicaid patients to federally qualified health centers to help offset costs relative to care coordination and behavioral health integration. An emerging state community care coordination model known as the Pathways Community Hub is also taking place. in 6 regions of the state. This model has been recognized for the Agency for Research for Healthcare Research and Quality, or ARC, and is being reimbursed by at least one Medicaid managed care organization in the state. And the model is currently under consideration for Northeast Ohio. Other roads to sustainable care for social determinant spending is happening around the country. As noted in the 2016 publication on Medicaid coverage for social interventions, the Milbank Memorial Fund outlines several paths to actualize sustainability of non-clinical coordination programs within the medical neighborhood framework. Despite its best intentions of national and state-based initiatives, regional entities remain the best option to ensure regional sustainability. Regional planning entities are the best positioned and best able to identify, respond, and create solutions to issues facing the region and helping to address the traditional health care cracks of the system. Communities can and must find solutions to questions like, how do we pay for bed bug removal? And who should pay for unmet and unfunded needs? Regional planning is best situated to align and direct funding for community health needs. The process allows communities to excise the devils out of the details. With me on the panel today to discuss these issues and more are Terry Allen, Commissioner of Health for Cuyahoga County, Kirsten Creation, Director of Community Outreach for the Center of Health Affairs, and Ben Millidan, Director of Health at the United Way of Greater Cleveland. It's my hope, as the Medical Director for the Ohio Department of Health, to help encourage and facilitate the seamless execution of regional health assessment and planning, both in Cuyahoga, the region, and the state. Through this process, we can build a win for this region and the state, and who knows, maybe a little magic could rub off for the tribe this year. I look forward to hearing more about the great work starting here and helping you along your journey. Thank you. So I wanted to thank the panelists again for participating. I'd like to start with a question for Terry Allen. And Terry, how do you help coordinate massive systems, and how do you lead with influence?
I think not unlike the elephant, sort of one bite at a time, I think is the short answer to that. So we've done, as you mentioned, our work in HIP Cuyahoga, the Health Improvement Partnership Cuyahoga, around our particular cycle of assessment. So what you're seeing today are 3 examples, distinct examples of assessments that are mandates, roles that different agencies play in the community, important roles covering different sectors, social service, clinical medicine, public health. And I've been fond of saying that you know, medicine and health were separated at birth, and we are amidst reunification. And it's inextricably tied together, our social services, public health services, and medicine, and we need to think about those, and I think in that context, that we all are heading toward the same end, the idea that we want a vibrant community, that we want a healthy workforce, that we want to create opportunity for everyone. And the State Health Improvement Plan work, and I think the great work that originated through the Health Improvement Planning work group at the state level that Dr. Moody initiated, really, I think in a very important way brought us all together. And that those requirements have set in motion, I think, a very, very big idea that I think if it's going to work, you have to embrace that large idea. That we agree that equity is important, that we agree that our success is based on everyone having equal opportunity to do well. And I think right now we know that the situation is uneven, and we need to begin to embrace the fact that our success is based on the collective success of our community. And I think we believe that in the work we're doing now around health improvement and work we're doing now around requirements for hospitals around assessments. But having the right people at the table that have that commitment and have that in their heart, I think, is essential for success. And I think we've made some good progress here. We have work to do, but we've made some good progress here.
Thank you, Terry. Kirsten, with all the various uncertainties happening in healthcare nationally, how does this impact your ability to perform healthcare planning?
So I think it makes it tricky on the implementation planning side. Obviously, everyone's aware that there have been so many attempts to dismantle the Affordable Care Act, and we know that we need to protect access to care because we know that's crucial for people's ability to stay healthy. So we need to be definitely staying focused on people's ability to access needed care and making sure that hospitals get reimbursed for the care that's provided in order to keep our hospitals healthy. But I think that despite all of the uncertainty that we've had recently in terms of what's going on at the federal level, the hospitals in the region have actually spent more than the state and national average on the combination of cash and in-kind contributions and community health improvement dollars. They're at about 8%, which I think speaks to their commitment to staying focused on community health improvement.
Wonderful, thank you. Ben, can you tell us a little bit about the Accountable Health Communities Grant, and how do you coordinate information flow between providers and community-based organizations?
Sure. Well, Accountable Health Communities is an award that the Cleveland area, through United Way of Greater Cleveland, was awarded about a year and a half ago. We were one of 20 organizations to receive this specific award nationally. So Ohio was the only state that had 2 of them. Cincinnati also has one. So that we were very excited to be chosen as one of the leaders in this area. And I'm just really excited about this grant. I think it's one of the most, if not the most important experiments in healthcare today, because it's doing a lot of the things that you talked about in your address. It's attempting to link the social service side and the health side in ways and bridge that yawning chasm that exists between those today. There are 2 primary ways that we're going to go about that. The first is a clinical-based intervention where we're going to have 211 community resource navigation experts going out from behind the phones for once, going into hospital settings and working with Medicare and Medicaid recipients. All Medicare and Medicaid recipients who go to a select group of clinics. There will be Care Alliance, South Point ED through the Cleveland Clinic System, Metro Main Campus, and St. Vincent Charity Hospital's psychiatric ED. All patients who go to those sites and have Medicare and or Medicaid will be systematically screened for the health-related social needs that they may have that would impact their health. Things like housing access, food access, transportation access, employment, interpersonal violence. After that, those who screen positive will receive a comprehensive 211 assessment, just like if you call 211 right now, giving them a full workup of the tailored and individualized workup of the different resources that might be useful to them. And then those deemed high risk will also receive ongoing navigation. So that's one part of it. The other part, which may be a little more germane to this discussion, is the alignment part, as they put it, where we'll be asked to convene an advisory board for this intervention that will align the community around addressing both the gap in social services and healthcare, as well as addressing some of the funding gaps in social services. None of the grant money can be used to address those gaps in social services, so that's an interesting challenge. But we'll be convening a whole broad swath of folks, the hospital partners that we're working with, community experts, agency experts in those areas of social health related needs that I discussed, service recipients, their families, academics, experts, funders, managed care plans, and getting all those folks together and trying to both look at the gaps in our community in health-related social services, as well as fixing those gaps and finding, as best we can, creative and sustainable ways to do that. Right. So I think I warned you not to ask me about the information sharing, because we could take the whole time on that, but that's going to be an enormous challenge for us, but something that we're definitely working on. On the clinical side of things, we want real-time sharing, and I just learned yesterday we've had one of our first successes in that, which Rita just gave me the thumbs up on, so we're very excited about that, getting our records to talk to getting the medical records to talk to the 211 records in real time to make sure that patient care is as seamless as possible. Has been tricky, but we're going to get there. And then sharing information around our community needs assessments. There's so much opportunity. United Way is already in a great position to do that. We just did a year-long needs assessment not that long ago, where that was not a health assessment specifically, but everything in there really impacts health to a point. And I think Kirsten and I have had brief conversations about how we could maybe coordinate that in the future, and Nancy and I have talked about that. So at some point, hopefully we can get together and see if there are some synergies, maybe through this advisory board, maybe through other ways to coordinate all of our work so that the social service side, with us as having that Switzerland-like position in the social service setting, we might be able to help out with that.
Wonderful. This is a question for all of you. How do you community plan around well-known issues relevant to the region, such as opioids, premature infant death, et cetera. How do you guys think about that in terms of your community planning?
Well, so I think we can take a very cogent example that we're amidst right now, the work around infant mortality. We know that Ohio is near the bottom, and certainly we know that the urban areas are drivers of the infant mortality rate, and the issue from an equity perspective is the challenge around the disparity between black and white infant mortality is unconscionable in our community, and we know in the state it is a major issue. So for us, that's something that we focus on and have focused on by getting leadership from the top. We know that our elected officials support the work. We know that the hospital systems have committed to the work collectively. We know that we're beginning to align efforts, that is, when people are applying for funds, seeking resources, that they're done based on a plan. The first-year Cleveland plan, where everyone is aligning specifically with the tenets of what the priorities are based on best practices, to begin to try to focus resources not by spreading this peanut butter very thinly across a community, but focusing resources on where we know that disparity is most pronounced. And I think you also have to recognize, I think, that there is no instant gratification in this sort of work, that public health efforts can take time for change because they weren't created overnight. I think a great example around commitment, looking at these sort of efforts, I see Danielle Price over here. Danielle didn't know I was going to say your name. How are you, Danielle? But I think Danielle's commitment as a community health planning and community engagement coordinator at university hospitals is a demonstration of university hospitals' commitment to having a right person in the room that comes and is engaged from the community, came up through that work, and sees the commitment that the hospital is making as critical, and has demonstrated that by having the right people that are engaging in the work. And so that means a lot in our work around assessment, having the folks that can relate back from a community engagement standpoint on these large initiatives. We have to ask first what the community needs. We have to talk to the community first before we act. And I don't think that the system is designed often that way. The choices on what we're going to fund and how the money flows isn't designed that way, but we've got to turn the system on its head. I'm reminded coming in today, listening to the story about my favorite Martian, the Opportunity Rover. You know, the rover that's cruising around 50 million miles away up on Mars as we speak. It was supposed to be alive for 40 days, 40 souls, 40 Martian days. It is now on day 5,000, cruising along there. And it's interesting that they're actually tilting the solar panels toward the sun. They hadn't recognized they could do that to extend the life of Opportunity. And so I think we have to look at that in the way that we look at the Olympics, Rita, as a sentinel event, look at this as an opportunity for our community, that we need to think differently. It's a big idea, and it's time to think differently.
Great, thank you.
So I always love when one of our hospitals gets a shout out, so love that. And I also would like to share an example which brings a lot of our hospital partners together, which is the Northeast Ohio Hospital Opioid Consortium, which is headed up by Allison Lepla, who happens to be in the audience today at our Center for Health Affairs table. And that brings together the Cleveland Clinic, university hospitals, the VA, St. Vincent Charity, and Metro. And we know last year everyone's aware of the horrifying statistics around opioids. Last year, Cuyahoga County, we had more than 800 fatal opioid-related fatalities. That was a 25% increase from the prior year. So clearly the hospitals are demonstrating through this consortium their willingness and desire to be part of the solution. So they're working on a few different things, which Allison shared with me recently. One of which is they're working on sharing best practices, which is great, talking about prescribing practices and how they can dig into their EMRs and find information that will be useful to combat the opioid crisis. And they're also working on increasing the number of providers who are trained to provide medication-assisted treatment.
Thank you.
I'll be speaking in more generalities, but United Way of Greater Cleveland's plan moving forward is to implement what we're calling a hub model, which is not to be confused with the Pathways Community Hub model you talked about earlier. But we in that community needs assessment that we did, that I mentioned, we were told over and over again, we should be doing more convening. We have contacts so many places in the social service, government, academic, business communities like no other. we should really be out there bringing people together to tackle big issues. So we've done some of that in the past, but we're hoping to do that in a more systematic way. So starting in July, we'll be bringing together all of our funded partners, all of our volunteers, as well as some other interested parties to really, as well as service recipients, as well as their families, to be able to tackle those issues and find the right way to get the right solution with the right people in the room.
Great, thank you. I think it's time that we take some questions from the audience.
So today we are enjoying a forum on the importance of community health planning featuring Terry Allen, Commissioner for the Cuyahoga County Board of Health, Kirsten Creation, Director of Community Outreach for the Center for Health Affairs, and Ben Miladin, Director of Health and Community Impact for United Way of Greater Cleveland, and also, of course, Dr. Clint Koenig, Medical Director for the Ohio Department of Health. As Dr. Koenig said, we are about to begin the audience Q&A, and we welcome questions from everyone, City Club members, guests, students, those of you joining us via our webcasts as well. And if you'd like to tweet a question, please tweet it at the City Club, and our team will work it into the program. Holding our microphones today are Content Coordinator Bliss Davis and Membership and Customer Experience Manager Corey Isler. May we have our first question, please?
So I have a question. I know you've talked a lot today about the hospitals and public health coming together. How do we engage other people, other stakeholders at the table? So our business community, our education community, so that we can have a more health in all policies approach.
So our work around HIP Cuyahoga, Jody, as you know from past experience, we've tried to bring in a range of different sectors. We've been told, and it's been said in different formats, that you have to sort of be aware of the supremacy of health. That we actually recognize that what are the big drivers of health, what creates health. We know that education, every year of education creates greater health. NIH data is very clear. Looking at addressing poverty, which is a huge driver of wealth, so that we can begin recognizing, as you say, the education sector can help us learn about how to best help and support their priorities. That the folks working in efforts around addressing poverty and social challenges, how can we in public health and medicine and a range of services, how can we support what they're doing in ways that we have not traditionally done? And I think that when we begin to think that way, we learn that from working with Better Health on a racial and ethnic approaches to community health grant by writing prescriptions for produce that doctors are giving out, the prescriptions for safe places to exercise, on addressing blood pressure gaps, thinking differently about bridging this work. I think then you start making the connections that if kids are successful in education, they will be healthier. They will do better. It will create opportunity for our community. And if we're working hard to create opportunity for education, and that will open doors for job opportunities, which will also help to further close that opportunity gap and that life expectancy gap.
Dave Margolis, over here, Metro Health, an old Brooklyn resident in Cleveland. And my question is related to that. In Cleveland, we're really lucky to have these strong community development corporations. And I'm wondering if you could speak to how we can use our community development corporations to approach and improve community health.
I want to. So I would say, do you want to?
Sure. I mean, we have some partnerships at United Way with some of the CDCs, community development corporations, who are, for the uninitiated, are organizations that are funded, I think, largely through federal dollars in different neighborhoods to promote development in those areas. So those are folks who have their pulse on the ground, who really know exactly what's going on in those neighborhoods, and can be invaluable sources of resource, both from the staff who work there, as well as linking to people on the ground who really need to have their voice heard, who may not have that opportunity very often. So I think they could be invaluable partners in the hub work that we'll be doing, and the accountable health communities work that we'll be doing, and it's a great place to start.
They were great with us around dealing on lead poisoning for many years. They've been partners. They're doing weatherization work in homes. They're doing issues around heating opportunities to deal with needs within homes. At the same time, we were able to integrate addressing lead hazards by braiding funding sources, community development block grant dollars, home weatherization money, and HUD lead money. So that braiding is an opportunity that I think we've already capitalized on that we can build on.
Hi, my name's Jenna Weisblatt. I'm from Northeast Ohio Medical University. And oh my gosh, I feel like I'm with my people. This is amazing, okay? I'm just overwhelmed by what you've said today. So, real quickly, the youth, our young people, greatest resource. We can ask them questions, but how are you all thinking about utilizing the youth to change the message, to bring it up, so that those young people who are in our schools today can in the future look back and say, oh yeah, we made this movement, this is us, this is a part of us. So I'm wondering, how are you all addressing that, and more than just, oh, they're gonna sit on our board or something like that? Thank you.
So I think I could try to address that. We're really excited as part of the 2018 planning, which we're currently doing. There's one of our members, University Hospitals, which is on a little bit of a different timeline than the rest of our members, so we're doing a shorter assessment for 2018 in collaboration with Cuyahoga County Board of Health and Cleveland Department of Public Health. And we're really excited. Next week, this was Terry's idea. We're bringing together a lot of people who have existing community voice data. So these are lots of great organizations like the Cleveland Foundation, Idea Stream, United Way, Asia Inc., Center for Community Solutions. So there's a lot of data that's already been gathered that basically helps bring the voice of community members to help inform the process. And so we're happy on a number of levels with that, to be able to bring the voice of the community in, and also to be able to take advantage of existing resources, which I think is a lot of what this is about, creating those efficiencies and not reinventing the wheel. So hope that helps to answer the question.
Hi, my name is Scott Frank from Case Western Reserve University, and with Cleveland being the most economically and racially segregated city in the United States, we can't talk about these issues without addressing particularly the issue of race and our distinct social geography in Cleveland. I happen to know that HIP Cuyahoga has taken a leadership role in this, and I'd like to ask Terry to comment on that, but also ask Dr. Koenig to comment on how the state is seeking to address these same issues across the state and not just in Cuyahoga County.
So I should first say that Dr. Frank, he's the one that developed the name for our coalition, HIP Cuyahoga, and if I remember right, the tagline was to be hip, be healthy, and be heard. So we'll give you credit for that, for the copyright. You can put that on your tombstone, Scott. It'll be a great epitaph. And so I think that, right, royalties. So in government, right, yeah. You have the eternal gratitude of the citizens of Cuyahoga County. So I think from my standpoint, we have a subcommittee, Eliminate Racism as a Social Determinant of Health, as Dr. Frank knows. And that really it really helped to focus our work and ground our work in equity. And that means engagement has to be central to that work. And that means that we're changing the way that we do business, and that we're thinking about collective impact. That is, how do we work together toward a common impact? And to the degree we can, all of us have agency priorities that we have to work on. How do we take a step back and put that as our central driver? We're dealing with chronic disease. We're addressing a range of other needs that we have around this bridging medicine and public health. But central to our work has to be acknowledgement of the history of our country, the history of the community, and how we begin to take that into account of how we change the way that we do business and how we change the power differential in conversations. And that means we need to take a step back and think differently. And for us, that has been a very much a grounding effect that we think is central, because we have been, all of us, everybody here, in a very well-meaning way, moving on our independent tracks to do work. It's time now that we begin to align. We begin to acknowledge the elephant in the room. And so that's, for me, has been a life-changing experience in the work that we've done. And so that's the big idea, I think, for our future.
I don't think I can follow suit after Terry. But from a state perspective, we have a lot of things going on relative to health disparity and health equity. First of all, we have what we consider to be a health equities officer within Ohio Department of Health to make sure that all of our processes, particularly our grant processes, have review for disparity and health equity, so that we're making sure that that lens is on our review process, as well as through other processes throughout our operations and functions. I think when it comes to the health planning and the new health planning cycles, we also have a commitment to making sure that health equities exist not only in certainly the urban centers, but also in the rural planning as well, because health equity exists all through, health disparities and health equity exist all throughout the state. So we really are looking at that as well to make sure. And then finally, again, with more of the collaboration around the community health needs assessment, which is on the hospital side, and the community health assessment and the community health improvement plan, or the CHA, the CHIP, on the public health side, through that collaboration, that we really want to make sure that, that health equities is not only addressed, but also clearly understood. And an example of that is, in my going around parts of the state and hearing people talk about health disparities and health equity, I'm not clear that people completely understand what health equality versus health equity are. And I think that comes across in some of the CHINAs, the community health needs assessments. And so part of what I feel like my role is in this space is to make sure that in their plans, that not only just keeping a hospital clinic, keeping their hours open longer for people is nice, but that's a health equality measure. How do you go into the areas where equity is greatest, where the greatest need is, and making sure that the planning, both on the hospital side and the public health side, are addressing equity, not just equality, within the disparity framework.
Thanks. So this is all wonderful and directionally correct and all of that. So I have kind of a specific question. We've heard a lot about data this morning, so I'm interested in each of you. If we were here 5 years from now, how would you have defined success? Is there one thing that you personally are saying, geez, if this metric changed, or if I could see improvement in this one thing, I would have felt like we would have been successful? What would be your priority around that?
I think if I had, great question, Jean. If I had to pick one thing, I think I would focus on infant mortality. Infant mortality is often an indicator of the overall health of a population, and we have significant challenges. I was sitting next to Bernie Kerrigan this morning, and I think we all know the stats, particularly the disparities, which are incredibly concerning. Black babies dying at 3 times the rate of white babies in Cuyahoga County. So I think if I had to pick one, I think if we could move the needle on that and erase that disparity, that would help us ensure that the overall health of the community had changed.
I suppose yeah, good job. It's more of a process measure, but I hope that throughout this, well, the two things happen. I'm sure that CMS will be looking to see if costs for the system are reduced overall through the Accountable Health Communities work in particular. And that's not insignificant. I know it's not exciting to talk about that, but costs are rising at pretty scary rates as far as funding, and we hope to maintain that as well. But flip side of that, I hope some of that cost, the lowered cost, is a redistribution towards more of a social service side. It's 2007 data, it's the most recent I could find, but most industrialized countries spend around $2 on social services for every dollar they spend on healthcare. And in the US, it's around 60 cents on social services for every dollar in healthcare. So when it comes to this conundrum of why we have such not so great health outcomes when we spend so much money on healthcare, I hope that there's some redistribution of that funding, and that will be an indication that we're valuing food and housing and transportation and all those social determinants more than we have been.
Amen. I think that Ben hit the nail on the head. I think that is a great measure. For me, I've been at this a long time in public health, 30 years almost. And for me, what I would feel really good about as we go through this process now of assessment, that we really see an alignment, not just on the assessment process, among the incredible capacity of our medical system. Metro UH, the clinic, St. Vincent's, we are blessed in this community with the medical capacity and alignment around health and social services in a very different and meaningful way. If we can, in this assessment process, break new ground and really, really change the dynamic, I think for me, that would be something I would feel really good about. And I think the opportunities and the possibilities are endless if we begin to bridge that gap that has existed, that reunification continues and happens. And I think then we'll see over time, we'll see that investment process change, the system begin to evolve as the hospitals work with us and recognize the community as their patient just as it is in public health. So I think that would be, for me, the big idea.
I think to answer that for myself is to take a slight deviation from what we're measuring and actually think about a model that the country of Bhutan uses to actually measure health. And the measure that they use, and I'm hoping no one here from the medical board is going to remove my license, but the measure that they use that I've looked at is gross national happiness. So wouldn't that be a great idea? Wouldn't it be wonderful if we could actually think about healthcare in terms of collective happiness for our region and our state and our country? You know, it is actually out there. If you go Google or use your favorite search engine to look up gross national happiness, it's actually operationalized.
I have a question. I appreciate the emphasis on social determinants of health and specifically on hunger. I'm just wondering, when I go to the doctor, I go through the routine questions, and the only one close to that is, do you feel safe at home, which is trying to get at domestic violence issues, of course. But what about food security questions? And is anybody asking those routinely? I'm not sure the best way to phrase it, but I mean in the medical, not to put all the weight on the medical side, but on the social service side. Do you have food security? Do you have enough food to get you through the month?
That is the goal of, one of the goals of the Accountable Health Communities grant, is to systematically be screening everyone for those kinds of things: food, transportation, interpersonal violence, a couple others I'm blanking on for some reason. But the, and when I say systematically, it's really trying to work it into the workflow as much as possible. We have some of our wonderful partners here today who have been helping us with that challenge. And just to make it as a routine part of medical care seems to be the idea that CMS has, and it's the idea that we're striving for too, that it's as integrated as possible and just treating the whole person and not just looking at pills and shots, not that those aren't important, but looking for all those things.
Clint, one thing I'd add is it has to be bidirectional. We collect data that sits at our place that the clinicians could use. We need to find a way to bridge that. We do newborn home visiting, and we collect data. How do we bridge that and create a bidirectional flow of data so we in the community can use the information, you know, dealing with the HIPAA issues that we all do? How do we get past that to create a bidirectional flow?
This has been, okay.
We have a question from Twitter. The Parkland, Florida shooting was 1 week ago. What responsibility does community health have to lead the conversation around ending gun violence?
I think I'll take a stab at it. I think it's a very, 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 very difficult dance between community health and public health and personal and individual liberties and rights. And I think it's an incredibly hard conversation to have, but I think it's a conversation we need to have in order to prevent violence and shootings like this.
I would only say that I'm in awe of the kids in Florida and the momentum that's being created. And I think that's what's going to change. That's what's going to change things. And I think that if that momentum can continue, it feels like people have had enough. I mean, we've all had enough. But I feel that the kids are going to change the world, and I think this may very well be a seminal moment.
That last voice you heard was Terry Allen, Commissioner for the Cuyahoga County Board of Health. He's appearing today with Kirsten Creation, Director of Community Outreach for the Center for Health Affairs, Ben Miladin, Director of Health and Community Impact for the United Way of Greater Cleveland, and our keynote was from Dr. Clint Koenig, Medical Director for the Ohio Department of Health. We've been enjoying a forum today on the importance of community health planning. This forum is part of our series on healthcare innovation, sponsored by Cleveland Clinic, Medical Mutual, and the Metro Health System. It is presented also in partnership with Better Health Partnership. We are deeply grateful for your support, all of you. Our community partners include the Center for Health Affairs and the Case Western Reserve University Master of Public Health Program. Thank you for your assistance in marketing our program today. And we welcome guests at tables hosted by the centers, and I thought that used to be the Centers for for more. Like, it's just the centers, it says. Okay. The centers and Circle Health Services and the United Way of Greater Cleveland. Pardon that moment there. Thank you all for being with us today. That brings us to the end of our program. Thank you, panelists. Thank you, ladies and gentlemen. Our forum is adjourned.
For information on upcoming speakers or for podcasts of the City Club, go to cityclub.org.
Production and distribution of City Club forums on IdeaStream are made possible by the generous support of PNC and the Raskin Family Fund, with additional funding from Robert Conrad, Cleveland State University, the Chautauqua Institution, the Cleveland Clinic, and the United Black Fund of Greater Cleveland Incorporated.